I'd like to thank Narasho IP and Solapur IP for this its big time course module. We have already have the wonderful sessions by the all previous speakers. And this will be the final sessions on amazing neurology. This is designed by the Dr. Anuparma sir. I have put my videos and the clinical photographs in this only. So we all know this is the case-based interactive session. More focus will be on the clinical clues with brief clinical presentation, and we are not going to the deeper of the investigation and the treatment. I request all first comment on the videos and the clinical signs and then jump to the diagnosis. So just observe this video. So just to brief you with the history, he is 8 years old male child with the history of sore throat since 1 month. With the history of sore throat since 1 month. History of joint pains. There is also systolic murmur on examination, hypotonia and hanging up the knee jerks. No history of any drug intake and no any significant family history. So how will you describe this video? Describe this video. Korea is right. So these are chaotic. Patient exhibiting the abnormal random movements, flowing in nature, chaotic, which is involving more of proximal limb of muscles than the distal group of muscles, restless, and will have some abnormal facial expression. And as already gets right, it is chorea. So with the help of this history, there is history of sore throat 1 month back, history of joint pains with this type of chorea, systolic murmur, hypotonia, and hanging up knee jerks. So what will be the clinical diagnosis, probable diagnosis? Yes, so it is the rheumatic chorea, and then you can plan the investigations according ESR, ESO, ECG, and the 2D echo. So, what are the clinical clues or what are the classical signs of the chorea? So, first sign, ask the patient to extend the both arms straight forward. So, after doing this, there will be the hyperextension at the metacarpophalangeal joints, and there will be the frequent flexion and extension at the wrist. So, like he is playing the piano. So this is called as a classical spooning sign or the piano sign. Second common clinical signs in the chorea is ask the patient to extend both the arms vertically up with the palm facing with each other. So there will be the hyperpronation of the palm, and this is called as touchdown or the pronator sign. Third sign, ask the patient to protrude the tongue and sustain it. So he is not, I purposefully made this video slow so you can get the. So this is just not able to protrude or sustain the protruding tongue, and this is called as Jack-in box, darting tongue, or the lizard tongue. So these are classical signs seen in the chorea. There is one more sign. This is not included in this milkmaid sign, right? And this is because of motoring persistence. Like he is not able to sustain the protruding tongue, they are not able to also maintain the pressure. So that will give the appearance like a milkmaid sign. So this is also characteristics of the chorea. So next, just try to identify the clinical picture and identify the sign. He is a 4 years old male child presented with the recurrent focal seizures, both febrile as well as the febrile. Family history not significant. Development is normal. The sign is on the face. What are these? Yes, that is the diagnosis. What is this sign? Yes, sir. Morris is angiofibromas. So we have exposed the child, and also on the back we have also find this hypopigmented patch. So this is Ashleigh macules. Okay. So we will go into the details of cutaneous markers. And this is characteristic in the tuberous sclerosis complex, as sir has already mentioned. So we will get the details in the cutaneous markers in the tuberous sclerosis complex and its significance. So first is the Ashleigh macule. So this is the Ashleigh. Okay. So these are hypopigmented patch. It is the earliest cutaneous manifestation, seen in the 70 to 80% of the cases. We can get the Ashleigh macules in the neonatal period also. Rest of the clinical signs like Shriganesh patch or angiofibroma, they comes in the latter, after 2 or 3 years of age. But we can get hypopigmented patches or Ashleigh macules in the neonatal period. So message is, observe this child in the future. After 2 years or 3 years of age, are they getting any Shriganesh patch or are they getting in the angiofibroma? Second cutaneous marker in the tuberous sclerosis complex is angiofibroma. As already told, rarely below the 3 years of the age, but after the 3 years of the age, we can get the angiofibroma in 50% of the cases. One more clinical cutaneous markers or neurocutaneous sign is the Shriganesh patch, and these are hypopigmented macules or Ashleaf macules. So these are areas of cutaneous thickening with papered surface seen over the lambosacral area. So what are the diagnostic criteria for the tuberous sclerosis complex? It is either two major features or one major and two minor, that is definitive tuberous sclerosis, or possible tuberous sclerosis complex, one major and one minor, or possible either one major or two or more minor clinical features. So this is the list of major and minor features, but if you got at least two major features, that is the most common, that is Ashleaf macules, Shriganesh patch, angiofibroma. If you got two major clinical neurocutaneous markers, you can make the diagnosis of tuberous sclerosis complex. So the next is the commonly seen in our day-to-day practice. He is a 5 months old male infant exhibiting this kind of abnormal movements, especially after getting up from the sleep. And these are occurring in the clusters. Yes. Yes. So this is the infantile spasms. How will you describe? There is a flexion. There is a flexion of both upper limbs with the head drops. Sometimes they are very close with the myoclonic jerks. So I will differentiate between myoclonic jerks and infantile spasms. Yes, as ma'am has already told, infantile spasms is after getting from the sleep. Epileptic spasms are common, but as ma'am told, appendicular, it is the infantile spasm. And axial, it is the ependyle form, and appendicular, it is the myoclonic jerks. And myoclonic jerks are within fraction of seconds. They are like lightning, just like a shock. Okay, so these are epileptic spasms. And mother has also told us as soon as this is started, because she is not worried about this. She is told like hey, kai nahi fakta dachakta. They are not giving the importance of the disease. But what mother should will come to you, or what will be her first complaint? That child has lost the interest in the surrounding. Initially he was smiling, initially he was looking to the face, initially he was interested in the surrounding, but as soon as since last 15 days, as soon as this movement has started, this child is not looking to me, she is not smiling to me, she is not interested in the surrounding. This will be the first complaint from the mother's side. If any mother comes with these complaints, ask the leading questions or show her, is your child is having this kind of movement, especially after getting up from the sleep, and she will agree, yes, these kinds of movements are occurring. Okay, after getting up from the sleep. So what I told, a smart mother often makes the better diagnosis than a poor doctor. So she will comes with you that my child is not looking to me. Initially he was looking, initially he was saying interested in the surrounding. She is not confused. My child is having epileptic spasms. She was just said काही नाही दचकतंय, सोडून द्या, तसं काही नाही, ते फक्त दचकतंय. Okay, so this child is 5 months, has no significant birth history, no neonatal encephalopathy. Still he is having this kind of epileptic spasm. So what will be the common neurocutaneous syndromes? Where will, apart from the birth asphyxia, West syndrome, we can get the epileptic spasms? Yes, right, very right. So upon the further examination, on the right thigh, as is already previously shown in the chart, this is hypopigmented, yes, Ashleaf macules, hypopigmented patches on the right thigh. Okay, so this is the.
Sir, will respond. Books given will respond to
so abscess seizure will respond to ithosuximab. These are epileptic spasms. Now ithosuximab is available, but that is abscess seizures. This is vigabatrin. This is epileptic spasms in tuberous. Epileptic spasms in tuberous sclerosis. So why it is important to find the diagnosis? Whether epileptic spasms are because of neonatal encephalopathy or whether is epileptic spasm are because of tuberous sclerosis. Why it is important?
Tuberous sclerosis spasm is very well respond to vigabatrin.
Yes. So treatment point of view is different. Only vigabatrin.
Not available, sir.
So recently it is available. Recently it is available. Since last 1 year, it is easily available. Before that, Sabric was there, but that is not available in the market. But since last 1 year, it is easily available in the Solapur also. So treatment differs. Okay, treatment of choice for the epileptic spasms in tuberous sclerosis complex is the only vigabatrin. So what message I want to give? So Suppose child is coming with the epileptic spasms, but there is no history of any neonatal encephalopathy. Okay, so think of tuberous sclerosis complex. This condition also present with the epileptic spasms. Another 7-year-old female child with the history of repeated abnormal movements, frequent staring looks that last for the less than 10 seconds, and these are several times in it. So how will you describe this video? So what is this? This is hyperventilation test. Yes, this is hyperventilation test. And after having hyperventilation, she went into the blank space. Brief automatism. There is a lip smacking. Yes, there is automatism. And immediately after she returns to consciousness, she is telling her name. And parents are telling, yes, these kind of things are occurring multiple times in a day. So you have already guessed the right diagnosis. That is absence seizures. Very classic EEG. As the investigations are not allowed in this model, I have not taken the EEG report or EEG picture. So very classic EEG. Generalized 3 heart spike and we discharges. Though this is not a generalized seizures, we will keep this as in the category of the generalized seizures because of generalized 3 heart spike and wave discharges. We can make it as an epilepsy syndrome also. So what is epilepsy syndrome? So like any other syndromes, there is a constellation of specific signs and symptoms that are specific to that condition only. Similarly, epilepsy syndrome will have specific age of onset. For the absence seizures, specific age of onset is for typical absence seizures. Yes, after the 4 years of age. Okay, typical age of onset. Typical signs and symptoms, absence seizures or staring, and typical EEG findings, generalized 3 heart spike and wave discharges. If we got all these features, we can label it as a syndrome, epileptic syndrome, typical absence seizures. So I have used the term the typical means there is some atypical also. So what is the atypical absence seizures? So they come before the 4 years of age. And what is the common cause for the typical absence syndrome? It is GLUT1 deficiency. GLUT1 deficiency, atypical absence will come before the 4 years of age. Similarly, West syndrome, as we have labeled the syndrome, specific age of onset after 3 months, after 5 months of age, specific signs and symptoms, epileptic spasms, specific EEG findings, hips arrhythmia. So all these 3 categories are made, so we can label it as one of the syndrome, that is the West syndrome. Okay. So as sir has told, drug of choice, initially we are using the sodium valproate. Drug of choice is ittosuximide. We have read in the book also during our PG or during our residency. But at that time, ittosuximide was not available. So in this case, now it is easily available. Ittosuximide by the brand name as a serious absence. Only one company has come with the ittosuximide, that is ittosuximide. And the common side effects with ittosuximide is abdominal discomfort. They will come with the vomiting, they will come with the abdominal pain. But I have seen very few cases that I have to stop the ittosuximide because of the abdominal discomfort. Okay, you can, if it is not available at your places or the periphery, still sodium valproate can work. Okay, so sodium valproate drug of choice is ittosuximide, but yes, sodium valproate also acts wonderful. So next video. So mother comes with this kind of, she was telling that child is consistently looking upwards. Consistently looking upwards. So the child is, yes? Sudden onset. Yes, I will stop the audio just a second. Yes, sir? Yes. So this is the child. We have complaining of, mother is complaining of, child is continuously looking upwards, and she has visited the village physician. Now started, child is crying, child is awake. Yes, I will. And child has visited the multiple village physician. He has started on the multiple anti-seizure medicines. But this is not a seizure. Child is crying. He is awake. Okay. So how will you describe these movements? Just describe the movements. Then we will come. What is the condition? Dystonia is there. Yes. Classical and dystonia is there. Yes. Classical ocular movements are there. So we can describe as a tonic. So there is a tonic eye. Okay. Upward deviation of the eyes with synergistic upward head movement. So this is, as madam has already told, this is the oculogyric crisis, extrapyramidal symptom, dyskinesia, can be labeled by various names. So this is oculogyric drugs, and the drugs Offending drugs, antiemetic metoclopramide, domperidone, yes, sometimes domperidone. Any other drugs? Antipsychotics. Antipsychotics, haloperidol, risperidone also now. The oculogyric crisis, this can turn the oculogyric crisis. So next case, 8-year-old child presented with the difficulty in walking, frequently falling, difficulty in climbing the stairs, running, and difficulty from getting up from the supine position. And this is the clinical oversight. This is the DM. What other clues we will have on the examinations? Yes, walking. And once again, this will come after the 5 to 6 years of age. What mother will recognize earlier? Frequent fall, that is also from the 5 years of age. Before that, not so comprehensive. This is SMA. Yes, absolutely alright. Delayed milestones. So delayed motor milestones. The child is not walking with the other children. The child is running behind with the other children. That was the first complaint from the mother at the 2 or 3 years of age when she started the walking. These are all over signs and they will come after frequent falls, will come after the 4 or 5 years of age. This is the pseudohypertrophy of the calf muscles. So these are the clinical clues. Apart from the DMD, any other conditions that can get the over sign positive. Suppose this is a female child. Then what will be the diagnosis? What will the possible diagnosis? So this is X-linked DMD, so they can occur in the male child only. But suppose this is a female child and she is having the over signs positive. Then what will be the conditions? This is a female child and she is having the go. This is a male child, but suppose this is a female child and she will have the over signs positive. SMA type 3. Apart from the DMD or sarcoglycanopathy or SMA type D, even polymyositis, even GID, juvenile idiopathic arthritis, discitis, they can also have the over signs. Okay, so apart from the DMD and DMD, these 4 conditions will have the over signs. So female child presenting with the over signs, either think of sarcoglycanopathy or SMA type 3. Okay. So next case, 3 years old male child, frequent right focal seizures, having this kind of red patch on the left side of the face. What is the patch? First, what is the patch? Weber syndrome is the diagnosis, and this is the Port-Wine stain. So, any child presented with the unilateral or bilateral Port-Wine stain with contralateral focal seizures. Okay, so your diagnosis will be the Weber syndrome. So we are not going to the detail of investigation, so MRI part was not included here. Next case, just observe the child. He is a 2 months old male child. He is presenting with the generalized weakness since birth. There is a history of similar hypotonia child. 2 months of age. Yes. And how will you describe the videos? Just I will play the video once again. No any anti-gravity movements.
It's hypotonia.
Yeah, severe hypotonia. No any anti-gravity movements.
G3 specific.
Yes, tongue fasciculations or he is crying, so we can't comment on the tongue fasciculation. Tongue fasciculation we have to see when the child is calm. Alert look. There is no any facial weakness or extraocular movements involved. Okay, so what are the clinical clues? Or diagnosis we have already guessed, but what are the clinical clues? Alert look. It's severe hypotonia. So we can keep as a clinical clue that alert look, loss of anti-gravity movements. Okay, over traction response, on dorsal or horizontal systems, ragged dog appearance. That cotton dog, we call it as a ragged dog appearance. He will have the totally hypotonia on dorsal suspension or horizontal suspension. Frequent ICU admissions for respiratory distress and requiring oxygenation. I think this is all the clues for the SMA. Okay, so before labeling someone SMA, be careful because it means you are writing the death certificate. So though it has some treatment, 15 crores and 16 crore injections, 2 or 3 injections, practically that are not possible for even for the middle class or higher class family. So it will have the poor prognosis. Next case, 2 years old male child with generalized seizures, developmental delay, and this type of implementation. Yes, the diagnosis is hypomelanesis of feto. And what are these? These are hypomigmented streaks, hypomigmented words in the embryonic line of Blasco. With seizures and developmental delay, as sir has already told, it is the hypomelanesis of Ito. Yes, in the line of embryonic line of Blasco. So, hypomelanesis of Ito is a hypopigmented verse of the skin. This is the third most common neuromuscular disorder. Pathophysiology, chromosomal mosaicism, CNS symptoms, seizures, intellectual disability. Now the Supreme Court has banned the term using the mental retardation. We have to now use the terminology as intellectual disability. We can't label anywhere because it was seen that the MRCP, it is common practice to write the diagnosis as the MRCP, MRCC, but now we can't write someone as a MR or someone as a mental retarded. We have to write the intellectual disability. Intellectual disability, developmental delay, deafness, visual problems, headache, and on MRI having some cerebral malformation. So this is hypomelanesis of it. Next, neonate with this typical clinical picture. What is this? Yes, that is the diagnosis. What is this?
Firebaldism.
Yes, firebaldism. Very right. So this is the white tuft of the hairs on the forehead or as a firebaldism. Okay. What other clinical signs you will look for Waardenburg syndrome? Someone has told us Waardenburg syndrome. What, along with the firebaldism, what are the other clinical signs in the Waardenburg syndrome? Okay, so heterochromia, not only the patient, but in the family members also. Okay, lateral displacement of the inner canthi and ask for the deafness. Then, as already told, it is a Waardenburg syndrome. Mode of inheritance, it is autosomal dominant with the mutation in the X3 gene located on the chromosome number 2q35. Another common neurogenic syndromes, just first told what are these? Yes, large, we can add the word large cafe-olate, hyperpigmented patch, cafe-olate spots. What are these? Yes, someone has told us it's neurofibromatosis. So what are the clinical clues in this picture? Patches of hyperpigmentation, large patches more than 15 mm. Also count the number, they are also useful. Okay, and what are these? These are neurofibromas. And now what is the diagnosis? Yes, it's a neurofibromatosis type 1. When you see cafe-olate spots or neurofibromas, also look for the axilla. What are these? Axillary freckles. And what is the sign? What is this sign is called as? Yeah. What is this sign called as? So this is a crow sign. Crow sign. It is seen in approximately 30% of the patients with the disease. Freckles are occurring in 30% of the people with the disease in the neurofibromatosis. So now we will come to the abnormal skull shape. Okay. What is the shape of this? Dolichocephalian. Which craniostenosis will cause the dolichocephalian? Sagittal craniostenosis with the dolichocephalian. Okay. Next abnormal shape. What is the shape of the skull? Brachycephalian craniostenosis. Yes. Bilateral. Here is the bilateral coronal. Here it is the bilateral coronal for the brachycephalian. Next clinical photograph for the abnormal skull shape or shape. Yes, and craniostosis, craniosynostosis.
One side.
Absolutely right. Unilateral. Unilateral coronal, and this is the plagiocephalian. Triangular head. What is the terminology or what is the skull shape? Yes, right. Trigonocephalian. Trigonocephalian. Which suture? Metopic suture, right? Metopic craniosynostosis, and this is the trigonocephalian. So, last we will come to the conclusion. Improve your power of observation. Try to foresee the events. Try to see the events which are not present but they will come into the future. Try to make the habit of making the provisional or clinical diagnosis. Try to write on the paper because your investigations will depend on them. We most of the time will say that the child is having the pathology in the lower motor neuron like GPS or SMA, and peripheral GPs are writing for the MRI and all things. So try to localize where is the lesion. So it is not a good practice to directly write a EEG and MRI. Okay, so make the habit of making the clinical or provisional diagnosis, make the habit of writing at the OPD or clinical papers. Okay, so that is the important. And in pediatric neurology, photo and video documentation is very important. For the seizure clinics, benign neonatal sleep mindfulness, we treated with the multiple anti-seizure medicines, no needs of any anti-seizure medicines, or in fact phenobarbital will increase that benign neonatal sleep mindfulness. Stuttering attacks, okay, these are one of the seizure clinics. So like apocytic crisis, as of previously seen in the video. So they can be treated with the multiple anti-seizure medicines, as sir has pointed. Multiple anti-seizure medicines will have the side effects on the growing pediatric brain. In adults it was okay. Their brain growth is already completed, but pediatric patients are the growing brain patients. Unnecessarily use of anti-seizure medicines will have cognition delay, will have some side effects, sleepiness, delay in the school performance. Okay, so be careful using the anti-seizure medicine or starting the anti-seizure medicines. Okay, and
Can reduce diagnose books given in 3D CT scan, 3D.
yes.
Can we diagnose with plain CT scan?
Yes, sir. We can diagnose with the plain CT scan also. So, as investigation part.
They written in book 3D
Yes.
CT scan.
Yes, in CT scan also we can diagnose the issues, sir. So we are always in the learning stage. We can learn at the initial stage, even at the 60 or at the 70 years of age. Patients, our juniors, can give us some clues, or we are learning from this. So it is, as sir has already told, make the mistake today, so we can not miss the subtle signs in the future. So visual clues are the clinical assets.